Testing is how you monitor the rate of infection and you control for it. And that is the whole tension in reopening. Everybody wants to reopen. You don't need to hold up a placard saying we want to reopen. Nobody wants to reopen more than me. Nobody wants to get the economy going more than me. Nobody wants to get on with life more than me and everybody else. We're all in the same boat. We all have the same feelings. The tension on reopening is how fast can you reopen and what can you reopen without raising that infection rate so you go right back to where we were, overwhelming the hospitals. The infection rate now is one person infects 0.9 other people. You can't infect 0.9, but it's basically one person is infecting one person, tad less. And I don't even know if it's a tad less because I don't even know that the statistics are that accurate, frankly. So let's say one person now infects one person. That's where we are now. When that is happening, the virus is basically stable. Where we were was one person was infecting 1.4 people. And that's when you have outbreak, widespread epidemic. We brought it down from 1.4 to 0.9. How did you do that? Those were the New York pause policies. Close down business, close down schools, everybody has to social distance, everybody has to take precautions, masks, etc. But it worked, and we went from 1.4 to 0.9. Wuhan says at one point they got down to 0.3, which is where you really start to see the numbers drop. But that's where we are. The tension is when you start to open business, you start to have gatherings, you put people on a bus, you put people on a subway, you put people in a retail store, then you're going to see more infections, you're going to see that infection rate rise, and then you're going to be back to where we were. So how do you gauge this, right? How do you calibrate it? That is all about the testing. And you have a very tight window. You're at 0.9 now. You can only go up to 1.2 before you see those hospitalization numbers start taking off again. You're talking about a very, very tight window that you have to calibrate. And this is all without precedent. So how do you actually do that intelligently? Well, you have to test. And testing informs the calibration. What is testing? Testing is you test. You test a person to see whether they're positive or negative for the coronavirus. There's also something called antibody testing, but let's put that aside for a second. On the diagnostic testing, positive or negative, you test a person. When you find a person who's positive, you then trace. Trace, they call them detectives. You find the person, and then you interview that person and find out who they came in contact, and you follow that tree down. That's testing and then tracing, when they talk about tracing. Trace all those contacts. And then you find the people who are positive, you isolate the positive people so they can't continue to spread. Tracing requires an army, literally an army. You would need thousands of people who just trace in the state of New York, right? Because any one person then leads to 10, 20 possible people who were infected. And you have to trace all through those people. You find a positive person, you isolate them. The trick with testing is not that we don't know how to do it. We've done it better in this state than almost any other state, almost any other country. It's bringing this up to scale. And these are private sector companies that are doing this. But we have done a very good job in testing. And the state has played a pivotal role in testing. You look at how New York, the number of tests we do. It's more than California, it's more than any other state, it's more than any other country. So we have had great success in ramping up testing. So we know how to do it. We know how important it is. We had that hot spot in New Rochelle, Westchester. It was the hottest cluster in the United States of America. And we jumped on it, and we jumped on it with intense testing, and it worked. we still have an issue, but it's no longer a hotspot cluster because you do a lot of testing, you take the positives, and you isolate them. This is now, the challenge is now bringing this up to scale, okay? We did 500,000 tests in a month. That's great news. Bad news is it's only a fraction of what you need. The more you test, the more information, the more you can reopen society. How does testing actually work? And this, again, you have to know the facts, otherwise this is all a blur and it becomes a he said, she said. There are about 30 private companies, large private companies in the country that are even international. 30 large companies make equipment to test. And they all have their own test, okay? So you have the Acme test, the this test, the this test, the this test. Those 30 companies have been selling their machines to local laboratories. And that's their business. They make a machine, Roche makes a machine, they then sell it to people, you have to buy their machine, and they then sell these local labs their testing protocol, because their test works on their machine. So you buy the Roche machine, you then have to buy the Roche test from the Roche Corporation. You buy the Acme machine, you then have to buy the Acme test from the Acme Corporation. And they sell these tests to local labs. We have about 300 local labs in our state who have bought these 30 types of manufacturers and 30 types of tests, okay? And then every time the lab goes to run that test, if I'm running the Acme test, I have to have the Acme equipment and the Acme vial and the Acme swab and the Acme reagents. What are reagents? When you take the swab, nasal swab, throat swab, you then test it with other chemicals. The other chemicals are reagents. Depending on what test you bought, they have their own reagents for every test. So the Acme test has one set of reagents, the Roche test has another set of reagents, and you have to go back to them to buy these reagents. So that's the basic chain. And it gets very complicated very quickly because you have the national manufacturers who sold their machines to local labs. The local labs then need to go back to that manufacturer to run their tests. And there's very little uniformity among the tests. So you're trying to coordinate this whole private sector system. We have some public labs. State has a Wadsworth lab, but the real capacity is in these private labs. So how do you bring this up to scale? And how do you cut to the chase on this one? We called the top 50 producing labs in the state and said, tell us what it takes to double your output, okay? And this is literally what they said. So there's no interpretation here. Most of them come back. Sometimes they talk about the equipment, nasal swab, vial, but what you see is most of them are talking about we can't get the reagents. We can't get these other chemicals that we need to test. Where do they get the reagents from? Their manufacturer who made the machine in the first place, okay? And they all say, with the machines we bought, we could actually be doing more if they would give us the reagents. That's the log jam that we are in. They bought the machine, they have the test, but they need the reagents to do a higher volume of tests. When you go back to the manufacturer and say, why don't you distribute more reagents? They say one of two things. I can't get more reagents because they come from China, they come from here, they come from here. We don't make them in the United States. Or they say the federal government is telling me who to distribute it to. And this is why I say you have the federal government involved in this situation, rightfully so, because the federal government is saying to Acme Pharmaceutical, give X to California, give Y to Chicago, give Z to New York. These manufacturers are regulated by the federal government. And the federal government clearly has a role in addressing this crisis.